This is Dr. Howard Strassler presenting the E-Lecture, Decision-Making in Restorative Interventions, Class V Cervical Lesions, Module B, Carious Cervical Lesions. The definition for Class V carious lesions are smooth surface caries on the facial and lingual surfaces of both anterior and posterior teeth at the gingival third. Caries is characterized on the facial surface as being a broad base of a triangle, then extending and becoming narrow to a tip of the triangle at the DEJ. At the DEJ, the caries spreads, and it spreads in such a way that it becomes a tip of a triangle again as it follows the dentinal tubules. So the progression of caries for smooth surface caries for the Class V are two cones tip to base, two triangles tip to base. Root surface caries morphology is slightly different than what we see with enamel caries. Generally, root surface caries, root caries, is characterized with gingival recession. The carious lesion is a softening of the root surface that progresses and follows the path of the dentinal tubules. Clinically, it's a discoloration on the root surface that's not hard, and that if we were to take a sharp explorer, it would feel soft and tacky in its initial stages. At those initial stages, the carious lesion is remineralizable through the use of fluoride-containing dentifrices, fluoride mouth rinses, and other remineralization procedures. The Class V caries continuum is very much the same as what we saw with the Class I and Class II, and Class III and Class IV as it relates to an enamel lesion. That a sound tooth has no caries. In fact, there's an equilibrium between the remineralization and demineralization process. Histologically, as the bacteria penetrate and the leading edge of the bacterial acids penetrate through the enamel, we'll see histological evidence of caries. Radiographically, the caries will then proceed to be through half the thickness of the enamel until finally there's definite enamel caries radiographically. The dentin is affected histologically while the enamel surface is still intact. At this point, the tooth is treatable with remineralization therapies. We reach the point where dentinal caries becomes more definite radiographically even with an intact enamel surface, and our restorative intervention occurs when the enamel surface starts to cavitate. At this point, we need to place our restoration. Now we add to this carious lesion continuum the fact that there's root caries. Root caries is somewhat different than enamel caries. We start with a sound tooth with no caries on the root surface. The root surface is exposed due to gingival recession. We still have this phenomenon of an equilibrium via the saliva, via the minerals within the saliva, and what we ingest, what we brush, what we place on that surface through the use of fluoride. And so this remineralization, demineralization is at this equilibrium. Eventually, as the caries progresses, we'll see histologic evidence of caries, until finally the dentin softened and we see radiographic evidence. Keep in mind we're talking about the initial caries lesion that starts on a root surface. Until finally we have definitive root surface caries. Now, root surface caries is not a cavitation as we see with the enamel, but rather it's a softening of the surface in a generalized way, and that softening progresses. If it's just on its initial phases, it's still remineralizable with different types of therapeutic actions through the use of fluorides, remineralizing agents, fluoride varnishes, but once we start to see it get deeper, our only intervention that will be successful is the placement of a restoration. So we talk about Class V caries, we talk about a number of different restorative interventions. Those restorative interventions can be preventive, or they can be more invasive through the use of restorative dentistry. Now we're speaking about a facial lingual surface with no evidence of interproximal caries. Our preventive means would be on enamel surfaces with no cavitation, where we'll use remineralization therapies using fluorides and other remineralization agents. We might preventively treat root surface caries on the cementum and dentin that we can feel that the root surface is a little bit tacky. We don't aggressively go after that surface, but we just note that it's not a hard, shiny surface. Once again, our interventions is remineralization with fluorides. As the enamel becomes cavitated or the root surface becomes extremely softened, we're then going to use restorative interventions with restorative materials, and we'll look at the restorative materials that we can use, from composite resins to glass ionomers to the use of dental amalgam. Now keep in mind the fact that we've seen caries in the cervical region, and typically Class V carious lesions are lesions of neglect where the patient has not taken care of their oral hygiene and removed the plaque sufficiently. That with these patients, even after restoration, we're going to have some very definitive preventive fluoride treatments. Prescribing for these high caries risk patients high fluoride containing dentifrices like Prevident 5000 plus, calcium calcium phosphate remineralization therapies, use of paint on fluoride varnishes. So when we talk about remineralization therapies, preventive means, looking at the initial carious lesion as being reversible, that our preventive actions are enamel demineralization is present with no cavitation. We go in with fluoride remineralization and or amorphous calcium phosphate remineralization using products such as MI Paste Plus. Our root surface demineralization with softening and a tacky surface, a sticky surface to the explorer, and a very shallow lesion, we're going to do the same type of fluoride remineralization therapy, amorphous calcium phosphate remineralization therapy. Sometimes we need to get invasive because, in fact, the lesion progresses and we need a restorative intervention. That these are not purely invasive treatments, but in fact are invasive because the patients are at high risk, combined with preventive therapies through remineralization, through oral hygiene instruction, through active surveillance to step in before any lesions develop. On the enamel surface, we'll see cavitation. We'll see surface roughening within the superficial enamel. The treatment might be only to smooth and contour the enamel, which may leave the enamel slightly under-contoured, combined with fluoride remineralization, fluoride amorphous calcium phosphate remineralization therapies. As the enamel demineralizes, we see this white spot lesion. The enamel's been etched by the acid attack, and or cavitation on that root surface demineralization with a deep structure softening. That we're going to do a tooth preparation. In the aesthetic zone, we'll consider a composite resin, whether it be a microfilm composite, a hybrid, or a nanohybrid composite. We might consider the placement of a glass ionomer, using some of the criteria we talked about in earlier lectures for the use of glass ionomer. If there are other factors at play that are part of seeing this caries occurring, such as dry mouth, drug-induced dry mouth, xerostomia due to medical conditions, radiation, dry mouth, and we see the caries, then glass ionomer is a better choice. If we see caries in the aesthetic zone, and caries is due to poor oral hygiene, bad dietary habits, and that we can change the patient's habits and in fact have them maintain their own oral health, then composites are indicated. In the non-aesthetic zone, our consideration is towards amalgam, in fact also towards glass ionomer. So let's take a look at certain circumstances. If we look at the upper left-hand corner where the green arrow is pointing, we have a soft carious lesion. It's cavitated on the enamel, extending onto the root, and in fact is subgingival. In that intervention, we're going to go in and restore, in all likelihood, on this maxillary mandibular third molar. We'll place an amalgam, or if it's strategic, extract the tooth. For the upper right-hand corner, we see a patient with radiation caries, a patient who's had radiation therapy in the head and neck region and is forming carious lesions around their existing restorations that are in place. Or it might be an initial very small lesion in a very difficult to access area on the cervical third, as we see in the bottom image. This is soft, it's rough, it needs a restoration. There'll be times that we may see demineralization and softening and cavitation in the presence of non-carious cervical lesions, where we see, as we see in the lower anterior here, that we can see that there's a notching but a carious lesion as well. And actually for this patient had had radiation therapy along with the removal of one of their sublingual salivary glands, so reduced salivary flow. And it's very difficult in order to maintain her, even with fluoride rinses. Her dry mouth, using oral saliva substitutes, she just is going to have just a horrendous time trying to maintain her oral health. In fact, down the road we see, as we've been restoring these teeth, that we're going to place crowns and place them subgingival. Or in the upper right-hand corner, we see an erosive area and a carious lesion forming in the center of this. We're going to restore this with a composite resin and see what happens. We'll follow up with preventive care. Another patient with radiation caries and making a decision as to how we manage it. We'll be restoring these with glass ionomer, but in all likelihood there were some bad decisions made by the oncologist when deciding on radiation therapy, in not consulting the dentist to see were their teeth at risk and perhaps these teeth should have come out. Patients with radiation therapy in the head and neck region have a decreased vascular blood flow, and when teeth are extracted, they're at risk at forming osteoradionecrosis, not having the extraction sites heal, and creating some significant problems. Or for these, I don't even know if these teeth have caries. These teeth have calculus around them. Aren't you glad you don't have a scratch and sniff card to see what this smells like? But this patient's been collecting the calculus for a significant length of time, and these teeth must be cleaned before we can have a definitive diagnosis as to what's happening. We look at number 6 and number 5, and we see an initial carious lesion in number 5 on the facial. Number 6 had been previously restored on the facial surface with a composite that wasn't retained. So we look at direct restorative materials for Class V caries. In the non-aesthetic zone, facial and lingual, we think about an amalgam. In the aesthetic zone, and where we can get adequate isolation, we think about composite. Where isolation may be difficult, or the patient has xerostomia, dry mouth, may be at risk for other root surface lesions, we'll consider using either a resin-modified glass ionomer or a conventional glass ionomer. And so here we're looking at a restorative intervention on a mandibular second molar on the facial surface. As we can see, it's a highly cavitated lesion. The dark brown black stain, if I were to take an Explorer, this is very sticky. It's as if I had stuck an Explorer into a leather belt. I can take a spoon excavator and actually peel this out. I have the dental dam in place. I was fortunate to get it on using a gingival retraction clamp for a molar. I've done my cavity preparation using a 330 burr or using a 35 inverted cone burr, removing the caries with a round burr, and then restoring it with an amalgam restoration. In cases where we see recurrent caries around existing composite resin restorations, as we see in this circumstance right here in the upper left-hand side, we're going to remove the entire composite restoration because you can see some marginal staining both on the mesial and the distal surface. It's difficult to place a dental dam for this tooth, and so we've placed gingival retraction cord to move the gingival tissue out of the way. We've beveled the enamel margins, but not the cervical margin on the root surface. We etch for 15 seconds, rinse and dry, place an adhesive, air thin, light cure, and then place our nanohybrid composite and polish and finish it. When we think about choices of restorative material, it depends upon the diagnosis. When we see caries due to xerostomia, a reduction in salivary flow, medication-induced xerostomia, Sjögren's syndrome, complication from radiation therapy and chemotherapy, or a circumstance where control of the condition is difficult. Use of a resin-modified glass ionomer due to its fluoride release in the marginal areas combined with the fact it's self-adhesive through ionic bonding, through the chelation of calcium and the hydroxyapatite, is to our benefit. And when we talk about Sjögren's syndrome, this medical condition, a systemic condition, the conditions associated with dry mouth and dry eyes, it's many of the different oral fluids are impacted. The patient may have rheumatoid arthritis or a related connective tissue disorder. It predominantly affects women who are over the age of 40, and they're associated with autoimmune diseases. And so when we look at restorative interventions, Class V caries in the aesthetic zone, our choices of materials are composite resin, glass ionomer, and that when we make that choice, it's based upon the caries rate, salivary flow, the ability to isolate the area with the dam or retraction cord. Is the condition caused by xerostomia, by an oral systemic condition or a localized condition, or is it merely a patient who hasn't cleaned their teeth? Once a patient changes their oral habits, a composite resin fits the paradigm for restoration, but the patient with systemic conditions that are not easily treated, certainly consideration towards glass ionomer. And so when we look at glass ionomer, and I repeat, we think about how we choose it. Resin-modified glass ionomers adhere by chemical adhesion, ionic bonding. When the patient has dental hypersensitivity, it's a better choice for a root surface restoration. Consider it's less aesthetic than composite, whereas composite may have a choice of 12 to 15 different shades. Glass ionomer, we may have a choice of 3 or 4. But it is the best choice for parents with best choice for patients with caries due to systemic conditions, due to its fluoride release and ability to recharge, combined with the fact it's self-adhesive. We consider composite resin for those patients where we can control and isolate the field, whether it's with the dental dam or it's with using gingival retraction cord. We're using adhesive bonding through etching and micromechanical locking to the enamel and dentin. It's our most aesthetic direct restorative material. Our consideration is if the patient has dental hypersensitivity, we may shy away from using the composite, because the acid etching may cause an increase in root hypersensitivity for these cases. For these cases, the glass ionomer is a better choice. In fact, during finishing and polishing of a composite resin on a Class V on a root surface may lead to an increase in sensitivity. Composites are more wear-resistant, more resistant to chemical erosion than glass ionomer. And it's for those patients where we're seeing Class V caries due to oral hygiene habit discrepancies and perhaps chemical erosion because of their diet. These are things that are changeable and modifiable through patient education and patient counseling. Our preparation designs differ depending upon the restorative material we want. Amalgam is a more definitive preparation, and in all cases, Class V preparations, the outline forms determined by the extent of the lesion. Amalgam needs a greater preparation depth with a minimum of 1.3 millimeters. Composite can be more rounded in their outline, more rounded with the preparation, less boxy with a depth of only 1 millimeter. Amalgam, we have distinct divergent mesial and distal walls, with an ideal axial wall being curved following the external of the tooth. The cavus surface margins for Class V's with amalgams are at right angles to the tooth. The composite resin has a similar design when we're restoring for caries, with mesial and distal walls divergent from the axial walls, with occlusal gingival and sisal gingival walls having a slight convergence to give us additional retention. But cavus surface margins are beveled for enamel at right angles on root surfaces. And so that's a difference from that of an amalgam preparation. Our outline form for a carious lesion, whenever possible we place the dam, that the preparation is defined by the extent of the caries. Take a look at the caries here and how the outline form's been defined. With the 212 clamp, I'm able to get the isolation to move the soft tissue, the gingival tissues away from the root surface and get my best isolation. If I couldn't get a dam on, I would be placing gingival retraction cord. Enamel margins, as we've talked about, we'll be beveling those enamel margins at 45 degrees, and the enamel margins will be half the thickness of the enamel. And here we can see that in this preparation design. If we take a look at the enamel bevel is about half to 1 millimeter long. It's been created with a round burr or with a flame-shaped diamond. On the gingival cavus surface margin, there's no bevel. And with no bevel, we have this right angle margin, and we can define it and finish the composite. Our choice of restorative material depends upon the diagnosis. I repeat this several times because some people get locked into they always use composite for Class V's, or they always use glass ionomer. In fact, we choose the circumstance. Caries due to poor oral hygiene due to drug addiction and abuse, those high caries risk patients. Patients who have chemical acid erosion due to food and beverage ingestion combined with poor oral hygiene, that once we see an improvement in their oral hygiene, the use of remineralization therapies, use of fluoride-containing toothpaste, we can use a composite resin. We still have to consider that this patient's still at risk, and we used to have to use good preventive therapies as part of their continuing dental care. If there's no change in habits, where we see large carious lesions on the facial surface but they don't keep it clean, our consideration is towards a glass ionomer restoration, as we can see for this patient right here. This is a resin-modified glass ionomer that's been placed on these root surfaces after preparation. As we've talked about, these are aesthetic materials. We're going to use glass ionomers for specific instances. We're going to use composites for other instances. The Class V is a controversial restoration because we have choices in the restorative material. Whether they be non-carious or carious lesions, there are a large number of opinions concerning how and when they work and what one should do. This program tries to list a rationale for the diagnosis and treatment decisions that you can make for your patients. You've been listening and viewing dental decision making and restorative interventions for Class V cervical lesions, carious cervical lesions.